Well, good evening, good afternoon. Welcome to the National Ovarian Cancer Coalition's Ask the Expert Facebook Live series. This afternoon, we will be discussing HRD biomarker testing and its impact on you. My name is Jennifer McClendon. I am the Education and Mission Programs Senior Manager here at NOCC, and I'm honored to be joined today by Dr. Scott Richard, who is a member of our Medical and Scientific Advisory Board, has participated in a number of key education initiatives with NOCC, and is a gynecologic oncologist at Summit Health in New Jersey. Today, we are diving into a topic that is really rapidly changing the landscape of ovarian cancer treatment, which is biomarker tumor testing. And today's conversation, of course, will be a special focus on HRD, or you may have heard of it called homologous recombination deficiency, which is a mouthful. But basically, HRD is more than just a buzzword in cancer research. It's a crucial biomarker that can influence your treatment options and your outcomes. But what exactly is HRD and why should you care about HRD? So, this is what we'll be discussing today with Dr. Richard. So, Dr. Richard, would you like to introduce yourself?
Sure, Jennifer. It's an honor to be here tonight. So my name is Scott Richard, and Jennifer said I'm a G1 oncologist. I've actually been honored to be part of the NOCC now for over 20 years. My first NOCC event was in North Jersey in 2004, and then really became involved with it when we were in the Pittsburgh chapter for 8 years after that. So it's been quite a while, I'm happy to be here today. And I think it's really important that we have the chance to talk about an emerging field within the treatment of women with ovarian cancer. HRD testing is really, and biomarker testing has really become to the forefront of what we're doing. And the way I look at it is that in the past, you were treated by the cancer type you had. And so if you were an ovarian cancer patient, you got treated because you had ovarian cancer with drugs that were for ovarian cancer. But this allows us to individualize the treatment a little bit, kind of focus in on certain characteristics about your cancer that may be different than the woman who has cancer, a few chairs down, to be a little bit more specific on how we can treat that. Um,
Yeah.
it helps us, individualize those therapies, which I think is very important. And then by
Mhm.
individualizing therapies, we can get better outcomes. We can decrease the toxicities that those patients are having, trying to make sure that, we're kind of being smarter about the way that we do things. Um, I think it's important to acknowledge that, treatments of women with ovarian cancer is very challenging. It's met with a lot of pratfalls, a lot of,
Yeah.
very difficult times. And what we hope to do is, over the course of this last 20 years, the efforts that the NOCC and we and G1 oncologists across the country have been trying to do for women with ovarian cancers to better these outcomes. And so hopefully what we can do today, Jennifer, with our, the
Mhm.
time that we're spending here, so we can help demystify a little bit about the shroud around what HRD is, what biomarker testing is, and try to come to some better understanding for our patients and their caregivers.
Really, that's awesome. I really appreciate it. Yeah, just bringing it down to a plain understanding is so helpful for sure. So thanks
Sure.
for setting that stage for us. And before I get to my first question, I just want to thank our sponsors for today's program, AstraZeneca, GSK, and Merck. Thank you so much for supporting this critical information and program. So now that you've set the stage, could you? This may be a challenge, but could you, in the simplest terms possible, tell us what a biomarker in general is and what role biomarkers as a whole play in our treatment planning?
Sure. I think that's a great question. So the way I look at biomarkers are it's kind of the individualized aspects of certain cell types. And these are things like proteins on the surfaces of the cells, characteristics within the cell that we can identify to help look at different aspects of it. And they can be individualized to to different tumor types. And what we know is that certain cells have certain receptors or certain proteins on the surfaces, and they can be overexpressed in certain cancer types. And those overexpressions can, be targets that we can then look at to help try to individualize therapy. And, these can be parts of the cell pathway, of the way that the cells grow, the way they signal each other, the way they hide from the immune system. So different
Mhm.
ways. And that's really what, when we're looking at biomarkers, we're looking at these things that we can look at within certain cell types, what, in cancer, in this case, being one of them, that we can use as targetable agents to identify those cells and then deliver our treatments towards those cells.
Targeted agents towards delivering targeted treatments. I love that. So that's why we hear the term targeted, I suppose. Yes, right?
Exactly.
Awesome. Well, thank you for that. That was very helpful. So when it comes to biomarker testing, say for example, when someone's newly diagnosed, should all patients get biomarker testing done? And is this an automatic process or is it something that's ordered, automatically, or how does that work?
Yeah, so this is a great challenge I think that we have right now is that
Oh,
you know, it's not necessarily ordered automatically, and it's up to the individualized provider where you're getting your treatments done.
okay.
And I think that that's something that's important. I think one thing we can do as advocates for patients is to help people identify, and ask very powerful questions to your
Yeah.
providers. Have you done any biomarker testing? What are some of the biomarkers that you look at for ovarian cancer that we can utilize to try to then target for my therapy? Personally, what I do is when a woman's newly diagnosed with ovarian cancer, is we send off for a full panel. That panel has a lot of sequencing efforts into it, and looking at targetable agents at different biomarkers. And those may not be things that we utilize right away, but it's
Mm-hmm.
information that I may need down the road. And what I always look at it is, I always want to know where things are before I need them, right? And so,
Right.
if I, am getting ready to go on a trip, I need to know where my suitcase is a few days before I need to find my suitcase to pack it. So I think those are important kind of things to look at, is to have that information available to us. So the way that we approach it, at least within my patient population, is we get those biomarker testings up front. If it's a patient who's been diagnosed in the past, or a new patient to my group who has been treated at another facility and they don't have those biomarkers, then we go and look for those biomarkers at that time.
Wonderful. That's really good to know that it's not necessarily automatic, but depending on practices, some of those great questions that you brought up that patients can ask, and then also how sometimes in your, like in specifically in your practice, how you go ahead and do a full panel just to kind of get you started and to kind of see what you know. That's great.
Exactly.
Awesome. Another question. So maybe you already answered this, but how accessible are these biomarker tests for patients across maybe different healthcare settings? I know we've heard there can be some challenges, and is there anything that you might suggest or something that patients should know about insurance coverage issues or different financial considerations when it comes to getting tested?
Yeah, so I think that some of the challenges right now are, where are these biomarker testings coming from? A lot of the larger institutional pathology labs are starting to try to incorporate some biomarker testing into their panels. So when a patient gets diagnosed with ovarian cancer, let's say, or a patient with colorectal cancer, they're starting to look for biomarkers that have been identified. And those panels are usually something that a provider would go up to their pathologist and say, I'm really interested in looking at HRD testing in my patients. And if that capability exists within the lab, then they would do that. There are many commercially available tests that are out there. They're send out tests that you can take part of the tissue that's obtained at the time of diagnosis and then send that tissue off for these commercially available tests. Um, a lot of the limitations I think we have are insurance coverage for those. Insurance companies are designed to get a pool of money and then allocate that money into the care of the patients that they're responsible for taking care of. And if they don't necessarily see the utility in biomarker testing, then that may be something that limits their ability to give access to their subscribers to
Right.
those biomarker testing. So I think that's a huge issue that we have, within clinical practice right now, is getting patients biomarker testing and then getting that paid for them. Now, fortunately, a lot of those companies work well with patients and with patients' insurance companies, and they try to make sure that it's as accessible as possible and the costs are known up front, so there's no issue. But what I would like to see is, kind of across the board, to see some of these insurance plans starting to realize the importance of how
Yeah.
these biomarkers are being utilized within our care for patients.
Absolutely. And I know that's something that the NOCC is very much a part of in some of those advocacy actions and making sure that we can pass legislation for some certain states to have biomarker testing coverage included. So that's definitely a great advocacy issue for us for sure. So thanks for explaining that. Really appreciate that. So today's topic, of course, is focusing specifically on HRD. So can you talk about HRD and exactly what it stands for. Like I said in our introduction, I know that many of you have probably heard the term or the abbreviation HRD, homologous recombination deficiency, but really, what does it stand for? What do we need to know about it? How does it, affect treatment decisions, particularly regarding PARP inhibitors, all the things. And I'll hand that over to you.
That's okay. No. So I think this is an amazing topic. And really, if you look back to 2016, when PARP inhibitors really started coming onto the field, we started to see the importance of HRD and HRD testing for patients with ovarian cancer. And homologous recombination deficiency, or what we call with HRD, is usually something we label as positive or negative for women with ovarian cancer. And currently, we suspect that over 50% of women with ovarian cancer are HRD positive. And this is a marker within their ovarian cancer cells that it leads to a deficiency in the DNA repair mechanism, specifically the double-stranded DNA repair mechanism. That probably what causes or leads to a lot of the cancer
Yeah.
development, specifically a part of it. But it's an actionable agent that we can then identify because this double-stranded DNA repair mechanism, if that's dysfunctional, then if there's an error in the processing of a cancer cell, it needs to get fixed, right? And so one of the things we do is we all have certain routines that we do. Like, I wake up in the morning, I give myself around 30 to 35 minutes to wake up, shower, brush my teeth, do what I need to do to get out the door. Every once in a while, I hit that snooze alarm one or two times more than what I should, right? And
Mm,
then I realize I've got to do something a lot quicker than what I normally do. You know, errors can occur in there. And if it, in my daily healthcare, if one of those is I forget to put on deodorant, there's consequences down the road. But if cancer cells, they rapidly divide. And if there's an error in their DNA transcript and their ability to kind of form that, then that can lead to a fatal error if it's not fixed. And so there are two repair mechanisms in a lot of cancer cells, the double-stranded repair mechanism and a single-stranded repair mechanism. And so with the HRD positive patients are, where they have a deficiency in homologous recombination deficiency, is their double-stranded DNA repair mechanism. Double-stranded DNA repair mechanism is taken out. And the way the PARP inhibitors work is it takes out its sister checking system, the single-stranded repair mechanism. And so if it takes that out and there's an error in the replication of the cancer cells, now the cancer cell has a fatal error. And that
right.
fatal error
Fatal
causes
error.
cancer cells to die. And so that's how we can be, how we're hoping to beat those cancer cells. And when you look at the studies that have looked at patients with PARP inhibitors, they break those women down into three different categories. Women that are BRCA positive, okay? Women that are BRCA wild type, or in other words, they're BRCA negative but HRD positive, okay? And then people that are BRCA wild type, in other words, no BRCA deficiency, and no HRD,
And no
okay?
HRD.
When you look at those populations, all BRCA positive patients are also HRD positive. They do the best, and we know that, and we've known that for a while, which is it's a good actionable agent, and it's something where we see that they have the better outcomes. But
So
the
those that
patients
are
that
BRCA positive and HRD positive do the best with the PARP inhibitors, is
they
what you
do the
mean.
best,
Is that what you
absolutely.
said? Okay.
Yeah, they have a better outcome
Better
and
outcome.
well. But the HRD positive patients, that are BRCA wild type, in other words, don't have a BRCA mutation,
Don't
they do very well also.
they do
Not
well?
quite as well as the BRCA positive patients, but significantly better than the patients that are HRD negative. So we know that if you're one of those 50% of women with ovarian cancer that are HRD positive, now the use of a PARP inhibitor in the front line setting, in other words, after you received upfront chemotherapy and you receive a PARP inhibitor as maintenance, you'll do better than patients that don't have that HRD.
So jumping ahead to a question that was down the line here, could I go ahead and ask them for those that don't have HRD, for maybe some of those, because we actually got a question in the chat already for, someone who's tested negative for HRD, what is the implication for that person?
So, I mean, I
Or
think
what
that's
does that mean?
right.
Yeah.
And I think that's a discussion you have with your provider.
Hmm.
There still is a role to use a PARP inhibitor if you're HRD negative, and you have that risk benefit discussion with your provider about, how does my HRD negative status affect me? But there are other medications that we do utilize in the frontline setting, like Avastin, that have been shown to
Hmm.
be beneficial for HRD negative patients. And
Yeah.
those are things that we're looking at, are there other potential new medications that we're developing that would fall into those other 50% of women that are not HRD
Right.
positive? Could we utilize those drugs for them? And so to provide them some similar outcomes.
Exactly. Okay. Awesome. Okay. That makes sense. It's a lot to digest, but I think you did a really great job of trying to break down there's an error in their routine. And
That's right.
so when there's an error in the routine, things don't happen. And when they don't happen in cancer's case, that's a good thing.
It's a good thing. We want that.
Okay. That's a good thing. Okay. Awesome. So aside from HRD, what are some other biomarkers? I know I've heard of folate receptor alpha or FRA. Some people may have seen FRA and HER2. Could you maybe speak to those as well?
Yeah. So folate receptor alpha and HER2/neu are both the receptors within on cells. And we know that they're overregulated in certain cells. Folate receptor alpha has been overregulated in 60% of women with ovarian cancer. And so we
Can
know
I
that,
ask a question?
sure.
When you say, I'm just curious, when you say overregulated, what does that mean
So folate receptor alpha and HER2/neu exist on all cells. Okay,
on
they're
all cells?
receptors
Okay.
on the surface of all cells. But what happens with certain cancer cells is they upregulate, there's more of those receptors,
More
right? And
receptors.
that may be part of why those cells are able to have immortality, grow more rapidly, and have their lethality that they do. And but what it looks for us, what it provides us is something to then identify a targetable agent to then deliver a smart bomb, I like to call it, a payload directly into the cancer cells, and therefore decreasing the effect that it has on normal cells, right? Because
Okay.
chemotherapy is toxic. It's toxic to all cells. And so if we can minimize the damage to other cells, then maybe we can, you know, have better outcomes from that standpoint. So what we know about with FRA or folate receptor alpha and HER2/neu is that there is upregulation or more of those receptors on ovarian cancer cells. Ovarian cancer, about 60% of them have more of the folate receptor alpha than you would see on normal cells. And HER2/neu, it's about 20% of women with ovarian cancer. So not as much as we see with breast cancer per
Right.
se, but it is something that we can then look to see as an area where we could then do some targetable agents. There are two new medications that have been released recently, Elahere for folate receptor alpha patients, and something called Enhertu, which is a drug for HER2/neu that allows us to deliver those toxicities, those toxic medicines directly to those cells that overregulate those receptors within ovarian cancer. So I think those are two really good ones that are out there that we've heard a lot about. And really, for our patients that are being treated for ovarian cancer, are things that their providers, if they haven't looked for, are in the back of their mind, things that they will look for at a certain point in time.
And how long would you say that we've had these biomarkers, HRD, FRA, and HER2 for ovarian? Has that been in the realm for a little bit, or are these fairly really recently new?
Yeah, so I mean, we've known about these for a while.
Yeah.
It's just what we do with them, right? And so HRD, I think, like I said, really since about 2016 is when the FDA approved the drugs, the PARP inhibitor drugs for ovarian
Yeah.
cancer. Folate receptor alpha, Elahere was in
That
2022.
was recent.
That
Yes.
was recent. And in HER2 is actually even more recent. I think that was
Yeah.
2023.
Yeah.
So, I mean, those are drugs that we really kind of look at. Though they're newer drugs. We've known about those receptors for a while, but that's the exciting thing. I mean,
Right.
we always want to do better than what we've done in the past, right?
Right.
And so having these, now something that we can use as targetable agents allows us to hopefully do better for patients now and in the future as we go through their journey with ovarian cancer.
Yeah, it definitely is a lot more exciting, a lot more hopeful for sure to kind of see that we are making progress. Not perfect yet, but we're getting there. And so it's really exciting to see this movement for sure. Yeah. Okay.
Absolutely.
Well, thanks for talking about all three of those as well. Um, let's see here. So, we talked about those three. Are there any other biomarkers that are maybe on the periphery that we're thinking about that might become something that we want to look at in the future that you know of or that you'd like to speak to?
I mean, there are a variety that are out there. I know some people have talked about things like PDL1, um,
PDL1.
yeah, which is it's something that we use with immunotherapy. With ovarian cancer, they're looking at different combinations of immunotherapy. It's not really as we've not seen as much benefit with ovarian cancer as we've seen with other cancer cell types, but it does mean that we're not trying in combination with other drugs. So that's another biomarker that people have probably heard about that's out there. And then I think that, some of the other ones like estrogen receptor positive status, there are some medications that we utilize out there that are looking at, what their estrogen receptor status is, other cellular pathways that are out there. We look at, CD4, CD6. So there's a different, CDK4/6, so different kind of inhibitor pathways that we're looking at. And I think that these are going to be things that you're going to hear more and more about. And I
Hear
think a
more and more.
lot of the research efforts now are looking at these targetable agents, because now that we've known about these cellular pathways for a while, and we've known of how they work theoretically within the cell, but now it's just a matter of harnessing that knowledge and harnessing that energy and going forward. And cancer research is a very, very slow wheel.
Yes,
I
yes.
liken it to, the old, Little House on the Prairie, the old bread mill, the old, grain mill, that stone wheel, and it takes a lot of inertia and a lot of effort to get that wheel moving. And then once it gets moving, it's something that's really beneficial, and hopefully we'll get some more and more information for it.
Absolutely. Yeah, awesome. Okay. Well, we got a question in the chat since we're talking about some of these newer ones. If you don't mind me asking, like, is it such a thing to if you were PDL1 positive, would that be necessarily a good thing? And from what I understand from a layperson is that that would be maybe a good thing because you have a marker to go after, right?
Yeah, and I think that
So
that's an important
maybe
thing. Yeah. Yeah, no, I mean, it's an important thing, and it gives us some more, and we know
more
that there are
information.
drugs that were, if you're PD-L1 positive, then, those are things that we can try, and and our journeys, our cancer journeys are individual ones, and we want to make sure that, having the knowledge of those markers, and definitely I would not frown upon not, knowing what someone's PDL status is, because then it can help us identify, because, if you look at the immunotherapies, Keytruda, I think Keytruda now has over 30 cancer indications for its use. It's just an amazing drug, and its
Mm,
sister drugs in the immunotherapy um, class of agents have been very successful in a lot of therapies. And so, and I think knowing those statuses are important because, like I said, combinations are going to come down. We're looking to see how are they tolerated by women with ovarian cancer, and how do they respond to that. So knowing those statuses are important, and that's why I send off, like, and I think, many providers, it's not unique to me, send off a real, like, broad panel, right? Because again, you may have a receptor, a biomarker that I would not expect on ovarian cancer, right?
right.
Maybe it's something we see on head and neck cancers, right? And so if
Hmm.
you're,
Right.
3, 4, 5 cycles into chemotherapy, and you have a very good performance status, and you have a willingness to fight, and I look down on that panel and I see something that, maybe interesting. It's a discussion that we have, and then,
Mm,
can kind of look at those things.
yeah. Yeah. And I think that's what I find exciting too is just the what do you call it? The layover of other cancers and what we can learn from other cancers. It's not necessarily in silos any longer, which I really find very interesting. Yeah.
Exactly. I mean, HER2/neu, for example. I mean, we for the
Right.
longest time we just thought it was a breast cancer, agent, a breast
Marker.
cancer
Uh-huh.
drug,
Hmm.
and now metastatic colorectal cancers, ovarian
Yeah.
cancers, pancreatic cancers. We're starting to see more and more of those drugs being utilized. Our PARP inhibitors were originally being used only in women with ovarian cancer. Now they're being utilized in women with breast cancer, men with prostate cancer. So we're
Yes.
seeing more and more benefit for these drugs
Yes.
across different cancer paradigms.
Very exciting. So as we come to a close, believe it or not, we're almost at our 30-minute mark, but as we come to a close, how could we leave today's discussion with helping patients to know how they can advocate for themselves when it comes to getting tested for biomarkers? I think you mentioned a little bit up at the front about maybe what some of those questions are, maybe we should repeat those, but and what challenges might arise when it comes to advocating for themselves, and just really what would be your advice for them?
Yeah, so I think that some of the challenges are potentially, feeling comfortable talking to your
Feeling
provider,
comfortable.
feeling
Yeah.
and feeling to your providers, whether it's your chemotherapy nurse, your mid-level provider, or your cancer surgeon or medical oncologist. You have to have that comfort level talking to them. And I
Sure.
think, voices by themselves are sometimes, weak, but they can be strong. But when you have many voices behind you, like of the other women who take part in our talks here in the National Ovarian Cancer Coalition, someone like yourself, Jennifer, who helps lead, this great aspect of what the NOCC does and empowers women and their care providers for with ovarian cancer. I think that strength, because you can come back to the NOCC or come back to one of your sisters with ovarian
Mhm.
cancer and say, "Hey, how did you approach Dr. Smith about this?"
True.
what kind of discussions did you have? Did you get any pushback, and how did you, because, sometimes it's good to know what worked for someone and what didn't work for someone, because you're not going to do what didn't work for them. Maybe utilize the tack that worked for them. And then, and I think knowledge is power, and that's what the NOCC
Knowledge.
does a lot for our patients, right? It
Yeah,
provides an area for you to come and access information that's
right.
been gathered for you, so then you can look to see, okay, how can I use this to enrich my cancer journey?
Exactly. And thank you for offering your part in this today in this discussion. And yeah, exactly. We have a multitude of newer education resources that we have on our website. So some of the questions to ask your doctor about biomarkers is on the site that you could definitely get familiar with and take that with you and hand it to your doctor. Have them answer those questions right there when you're in the room. So that's definitely a tool that could be very useful. So. Well, I just want to thank you so much. I know that went quick. We really appreciate you spending your time with us to talk about such a hot and important topic. We hope that we've clarified and helped clarify some of these tests that can influence treatment options for you today, including those like PARP and including those like the antibody drug conjugates that Dr. Richard mentioned, such as Elahere. But, again, for if you're looking for additional information on these or videos on this topic, we have our YouTube channel where we have some additional videos on this topic as well. So we hope that you check those out. But really, just stay informed, stay hopeful, and thank you so much for being an important part of this conversation today. Thank you.
Thank you, everyone.